This is Dr. Christine Bachman, and I'm going to be narrating this cataract surgery on a patient who presents with a dense white cataract. If you can't see the cataract there, then you may need cataract surgery yourself, because that is a dense white cataract, which is when the crystalline lens that everyone has in their eye turns cloudy and forms a cataract. And in this case, it's turned so cloudy it's white, so it's classically called a dense white cataract. So here I've already injected trypan blue through the paracentesis wound in order to stain the anterior capsule. That will allow for better visualization and a more controlled capsular rhexis. What I'm doing now is sticking a needle in, I believe it's a 27 gauge needle, in order to decompress the cataract. Sometimes cataracts that are dense white can be very pressurized inside the capsule, and all that white milky stuff is actually liquid and will come out. Here I didn't aspirate too much. If you successfully aspirate a lot, then a big puff of smoke will appear, and that's liberation of the cataract contents inside. Now I'm making the main wound, and I first made the main wound smaller purposefully to allow equalization between the chamber, the anterior chamber and the outside of the eye to occur more slowly, so as not to radialize the anterior capsule. I am attempting to perform the capsular rhexis, however, because the wound is on the smaller side, it is more difficult, so I'm going to make the wound larger and use the capsular rhexis forceps in order to complete the rhexis. So here I'm going back in. I'm trying to go in the same path that I made initially with the keratome. And there I've made it larger. And now I'm going in now for the first time with the forceps, which is easier for me to make the rhexis. The capsular rhexis is basically a window into the cataract to allow me to aspirate the cataract fully with leaving the posterior capsule intact. Again, it's easier to think of the cataract like an M&M with an outer shell and an inner chocolate center. So basically I'm tearing the outer shell, the front part of it, and the goal of the surgery is to leave the posterior shell intact while removing the chocolate center, the cataract. And if you break that posterior shell or posterior capsule, that's called a posterior capsular rupture, and you can still have very good outcomes with that, but it will lengthen the surgery, and sometimes a patient may need a second surgery. So now I'm going in with the phaco probe, which is a probe that breaks up the cataract using ultrasonic energy, and I'm doing the classic divide and conquer technique, which is a safe way to remove a dense white cataract so as not to cause too much disruption of the posterior capsule while breaking the cataract up into small pieces. So basically I'm going to break it up into 4 quadrants. That's divide and conquer. So here I'm making the first groove. It's important to make the groove big enough, which I'm widening the groove here, and also deep enough. Again, if you go too deep, you can break through the posterior capsule. And now I'm using the Cybele chopper. Looks like I am cracking it instead of making the classic 4 quadrants. So I've broken it up into 2 quadrants, and now I'm swinging it around so that I can grab it with my probe. I can grab one heminucleus, bring it up, and then chop it in the anterior chamber. So there I've chopped it and aspirated a section and just slowly plugging away. It's important to keep the pieces in front of the probe like I'm doing. That allows for the piece to tumble into the probe and aspirate easily. And I'm using the chopper to reposition the second heminucleus. This is the fun part. Just cleaning up this cataract, and behind it you can see the beautiful red reflex, which people normally have when they have a cataract, but this is so dense that you couldn't see it before until now. And it's important when you take the last few pieces out to go slow. You probably have higher settings that you're using when you are removing a dense white cataract, so it's easier to break the posterior capsule. And now I'm using the probe to aspirate the remaining pieces of the cataract. And just cleaning it up. There's some pieces stuck in the corner, and sometimes with a dense white cataract there's not a lot of cortical material left, but there is more cortex than expected here, so I'm cleaning that up by various maneuvers and manipulations of the eye to reach all those pieces that kind of hide out in the corners and the angle of the eye. So it's hard to tell, but there is a posterior capsule there, and it's hard, for a layperson to see that the shell of the M&M is intact. The front part of it is obviously opened. And now I'm just continuing to aspirate it. This is nice with the hand piece, being able to break it into 2 pieces and bimanually remove the remaining cortical material. And now I'm injecting viscoelastic to fill the capsular bag or the shell of the M&M to allow for appropriate cushioning and centration of the beautiful Elcon lens going in. And using the chopper to position it center before irrigating. And aspirating the rest of the viscoelastic out and centering the lens. And now I'm using just saline or water on a cannula to hydrate the wound. So this allows for hydrostatic closure of the wound without having to use a suture or stitch. And I'm checking the wound now with the Lexel sponge, seeing that it is leaky and just not wanting to take any chances. I put a stitch with a 10-0 nylon suture. And that stitch will be removed within 2 to 4 weeks post-operatively. You can see that the cornea has wrinkles in it. It's indented. That's due to the stitch being fairly tight here. Maybe a little too tight. That's not a big deal. It just means that this cornea is going to have some astigmatism or a shape to it that will only get better once that stitch is removed. So post-operative vision may not be terrific, although they did have hand motion vision before, meaning they could barely see the hand in front of them, not even the big E on the eye chart, but the dense white cataract. And I'm just making sure the eye is of normal pressure, physiological pressure, the finger test, and I'm rotating the suture so that the knot is buried. That is it. Thank you for watching. This is Dr. Christine Bachman, and that was a dense white cataract surgery narrated.